response detection. So the virus detection, we have two methods. Either we can go with a viral nucleic acid, which is a like a PCR test, or there is a viral antigen detection test as well. So as of now, we don't have any approved viral antigen detection tests. We have the viral nucleic acid test or the polymerase chain reaction. The one what we are using is a conventional PCR approved by NIV. Now there is one more test coming up, which is a rapid PCR, or whether it's a or otherwise called the point of care PCR, where we can do the test even in a small labs. Whether it's a closed system using a a chip, where the main advantage is that while collecting the sample itself, you are collecting it in a lysed medium, so the virus will be inactivated at that point itself. So you don't need a higher biosafety profile or biosafety parameters in your lab. In US, already GeneXpert has already approved the same method is followed. In India also, very soon we'll be getting one machine by Ball Bio. And in the immune response detection, we'll be basically looking at specific antibodies. There are CAR tests available, and ELISA titers are also available. In the CAR test, we'll be looking at IgM and IgG. And you should have a clear-cut idea about these IgG and IgM response. As you can see here, the IgM response starts on day 7, that is just following the window period, and it lasts up to day 21. By day 21, it will be just declining, and the IgG response will be starting at about day 14, and it can last for like more than a month. So the importance of knowing this is, like, in the initial period, you can have a PCR positivity, but your IgM and IgG will be negative. Then later on, you can have an acute phase where PCR and IgM will be positive. But this antibody test, or the so-called rapid test, these are basically used for surveillance purpose only, or as an additional tool, you can use it with PCR. As a standalone tool, it cannot be used as a diagnostic modality. WHO has not approved these rapid antibody tests for diagnostic purposes. Now coming to the testing strategy, these are the group of persons whom we are testing, like the persons with international travel in last 14 days with symptoms. So these persons on quarantine if they are developing symptoms, or symptomatic contacts of lab confirmed cases, or all symptomatic healthcare workers. All symptomatic healthcare workers may be slightly difficult at this point, but at least symptomatic healthcare workers in the COVID care hospitals, and all hospitalized patients with severe ARI. I don't think we all are testing these things, but we will have to start this also. Any severe ARI admitted in the hospital also has to be tested. And asymptomatic, direct and high-risk contacts of a confirmed case should be tested. This is asymptomatic. So even if they are asymptomatic, you have to test once between day 5 and day 14. So these are the new testing guidelines. And coming to the reduction of the spread, just giving a quick idea, like the transmission can be reduced, or the R0 or the reproductivity index R0 value can be reduced either by reducing the susceptible persons. The option is vaccine. We don't have any vaccine like that, or reduce viral load and duration of infectivity. So there is no antiviral drugs available right now. There are a few antiviral drugs which we will be discussing. But having a drug which can reduce the viral load is having a definite value in reducing the R0 value and reducing the infectivity. And obviously the non-medical public health interventions like the social distancing or our like lockdown or shutdown, whatever it may be, all these things will help in reducing the R0 values. Now coming to the interventions, why we need intervention. So this, you can see, this is the maximum capacity where we can accommodate the patients. So when without any intervention, if the numbers are going up, like we cannot accommodate in the available healthcare facility, and our the patients will not get proper care, and or we will not be having enough spaces in our ICU to admit these patients. So you will have to delay this epidemic peak and reduce the height of the peak. And the spread of the cases should be, you have to spread it over the time, and so that the curve will be flattened. Even our shutdown is also going to help in this way. Now, coming to the topic proper, like what are the drugs used in the treatment of COVID-19? None of these drugs have shown the proven efficacy. All these drugs are in the trial basis. And in WHO, there is something called a WHO Solidarity Trial, which is looking at different options. The Solidarity Trial is having these mainly four arms, where it will be looking at lopinavir, remdesivir, then hydroxychloroquine, and interferon beta, basically. That also we'll discuss in later. And the therapeutic options are, there are so many drugs tried, basically remdesivir, chloroquine, hydroxychloroquine. So in that, hydroxychloroquine is available in India. Lopinavir is also available, is used as an HIV drug, but the recent trials has shown no benefit with these drugs. Then other drugs like darunavir, ribavirin, which was used even in our Nipah outbreak, Crimean Congo hemorrhagic fever. So that has also shown some effects in these MERS patients, but not studied in SARS-CoV-2. Then favipiravir, then that is also reports with MERS, but not with SARS-CoV-2. Then the Convalescence Era, that is the recent JAMA paper has again shown, even though it is only 5%, good improvement with that. Monoclonal antibodies, delfinavir, oseltamivir, and other immunomodulatory drugs and biological therapy. Obviously, IVIG has also been tried. Now coming to the remdesivir, this is an adenosine analog with a broad spectrum of antiviral activity. This was extensively tried in Ebola, Marburg, RSV, Lassa, Nipah, Hendra, etc. But again, the effectiveness was not proved in that case. This was basically developed in 2014 and 16 during the Ebola outbreak in West Africa, and in the recent outbreak, the first 3 cases out of 12 in US was treated with remdesivir, and they claimed that there is an improvement with remdesivir. The GI symptoms and mild transaminitis, elevation in SCOT, SCPT is a main complication, and there are almost 4 ongoing trials on remdesivir, main 4 ongoing trials. So these are the other trials. I've already told 4 main trials, and again 2 more other trials are also there. And in the Solidarity arm also there is a remdesivir trial, and this is given as a 200 mg IV loading dose, then 100 mg once daily maintenance dose. So this is a dose available, but the issue is we don't have a remdesivir in India right now, and the countries like US, they are not exporting the drug. So getting the remdesivir in India will be extremely difficult at this point of time, I feel. Now coming to the hydroxychloroquine, I'm not going into the details about all the studies, literature available, all those things, but there is a new paper which is again tested in 31 patients in each arm. The dose used is only 200 milligram twice daily from day 1 to 5. Please note the dose used is only 200 milligram twice daily. There are many reports coming up where even the doctors have used very high doses, something like 600 BD and all, and developed cardiac complications. This hydroxychloroquine is a drug which is known to produce QT prolongation. So be careful about that. And regarding the prophylaxis also, there is no trial or data available. Only there is a recommendation by ICMR and WHO without proper data supporting that. And with the recent paper, it has shown there is a time of temperature neutralization and the remission of cough. These are all minimal symptom improvement, like only 1 day reduction in cough and 1 day reduction in fever. This is what is shown, and again the CT clearance is also better in the hydroxychloroquine group. But we at this point we will have to accept that this is the one drug which has shown reduction in the viral load and mild clinical improvement as well. And this is the paper which was looking at the combination of hydroxychloroquine and azithromycin. In fact, this is a very small size study with, and it was not powered for the efficacy. And out of 20 patients, the dose received was 200 milligram 8th hourly, and the azithromycin was given to prevent the infection. And later on, the patients, here you can see This is the hydroxychloroquine and the control arm. Here in the control arm, you can see the percentage of patients with PCR positive samples, and here you can see here the reduction here you can see significantly, and here also you can see the patients with hydroxychloroquine and azithromycin has a better viral clearance than hydroxychloroquine alone. So with this study, actually there was a conclusion that adding azithromycin to hydroxychloroquine may be a better option, but I've already told you this is a very small size study. With only this one, we cannot make conclusions. And be very careful. Azithromycin can also like prolong QTC, and you should be well aware about the drug interaction between hydroxychloroquine and azithromycin, and we will have to monitor the QTC very clearly. Now coming to the interferon, there are two types of interferon. One is interferon alpha and interferon beta. This interferon alpha, this was a big news in many newspapers, and it was known as magical Cuban drug. But if you see the data, there is no published data, only very like a few patients, and that also this was combined with the corticosteroids, as you can see, like the patients, like 9 patients and all. But in that group, there is a resolution of the chest radiology findings and the improvement in oxygenation. Again, we will have to wait for like more numbers. But the issue is, this is always given as an inhalation therapy. And as you all are aware, all the nebulizations, when we are treating this SARS-CoV-2 infection, will be an aerosol generating procedure. So you should be very careful when using an interferon. In Kerala, the government has already applied ICMR permission, and we are planning to get this drug in Kerala. And another problem is the Solidarity trial. This actually include interferon beta, not interferon alpha. So we will have to start a separate arm or a separate trial, and we'll have to continue with interferon. Another problem with interferon is, towards the end of the disease, or when the patient is admitted in the ICU, there will be a phase of cytokine storm. And when at that point, if you give the interferon, the tissue damage will be aggravated. So interferon should be initiated at an early stage before the cytokine surge, or otherwise you will have to look at IL-6 values, etc. And we'll have to see that the IL-6 values are not very high, and we'll have to make sure that there is no cytokine surge before starting interferons. Now coming to the convalescence era, this is another treatment which has shown efficacy, but again very limited number of patients. Here what we are doing is, like you follow up the patients who are already recovered from the disease, or the survivors. Then once these persons the clearance has occurred, that is you will have to check serially the viral PCR, and once it is negative, and like after 28 days, you can check the antibody titers, and if there is a significant antibody titers, we can extract the plasma using the plasmapheresis, and that can be used as a prophylaxis therapy and again for the treatment, as you can see in the diagram. So this is the JAMA paper where they have looked at the difference in 5 patients, and here they have not given plasma alone, but as you can see, the patients have received methylprednisolone and other antiviral drugs as well. But as you can see, there was definitely the CT value. You can see this was high. That means there was a good viral clearance. Then the SOFA score was significantly coming less after giving the plasma. And again, the PF ratio was improving. That means the oxygenation was really improving. And there was a decrease in the temperature spikes as well. So even though this is 5 numbers, this has not shown any significant adverse effects. And even in China, this was studied extensively. And the difference between the whole blood donation and the plasmapheresis, or like an apheresis, is like the site of collection. You cannot collect it from everywhere. You need an apheresis machine. And during the blood donation, we'll be donating only 200 to 250 ml. But here, like if the weight is more than 55 kg with adequate albumin level, we can extract up to 800 ml, and we can divide it into 200 ml bags. That means we can divide it into four 200 ml bags, and one bag that is 200 ml is only required for treating one patient. So that is the advantage, and you can store it for a longer time. Usually, you will have to check the ABO compatibility and transfuse, or we will have to take an only AB group, then transfuse. Another advantage is if after like 1 month or so, if you check the antibody titers again, and there is a significant antibody titer in the blood, the survivor can again donate the plasma, and that also can be used for treatment. And compared to the other drugs, it's not very expensive. In Kerala, we have already formed a protocol, and this is submitted for approval, and like awaiting ICMR approval, and we need an ELISA kit to look at antibody titers. So that kit is also expected in Kerala in another few days' time. And regarding this study, which is published in JAMA, basically these parameters were looked at, especially the severe, the life-threatening diseases, all those things. So here also, you will have to start the plasma when the patient start developing hypoxemia. There is no point in giving the plasma after the ARDS is established. So before the oxygen requirement is going up, at that point itself, we will have to initiate the plasma, and obviously we will have to get an informed consent, and all the survivors data we will have to keep, and we will have to counsel the survivors about the possibility of this modality of treatment, and probably they all should donate the plasma as well. Now, coming to the other issue, the cytokine storm is a main complication in severe COVID-19, or it is otherwise called reactive hemophagocytic syndrome, or also called macrophage activation like syndrome, MALS, or called MAS macrophage or HLH, hemophagocytic lymphocytic hemophagocytic syndrome. So here again, we have different scoring. Previously, the 2004 HLH criteria was utilized. Now there is a specific score called H-score, where you will be looking at temperature, organomegaly, ferritin level, the number of cytopenias, the triglyceride level. And you can see you don't need a very hugely elevated ferritin to diagnose MALS in always. Like even if the other parameters are other parameters are satisfying, definitely we can make a diagnosis of HLH. And the serum fibrinogen level, the liver enzymes, and see the hemophagocytosis in bone marrow. This is, if it is present, it gives only additional value of 35%. That means up to 70% of the patients, or only 70% of the patients will be having a hemophagocytosis in a bone marrow examination. So even without a bone marrow change, you can diagnose hemophagocytosis. And once you diagnose the hemophagocytosis, other parameters like an elevated interleukin level 6, or elevated CRP, or elevated soluble CD25, all these parameters can also help in making the diagnosis. Now, once the diagnosis of HLH is made, there are many treatment modalities. So usually viral infection associated HLH, the main modality of treatment is giving steroid. But the same way you can give other therapies like especially like interleukin 6 blockers and the interleukin 6 receptor blockers. This tocilizumab is an interleukin 6 receptor blocker, which can be specifically used in HLH and again in severe SARS-CoV-2 death line changes as well. This is basically this tocilizumab is used in rheumatoid arthritis as a biological therapy. The main problem is, as you can see in the diagram, this interleukin 6 receptor blockade, the serious infection incidence is high. So whenever we are using these biological therapies, the chance of secondary infection is there, and you should be well aware about that. This is also like one of the arms in Solidarity trial. and different dosages are tested. The high dose where the 200 milligram initially, then you look at the response, re-evaluation, and the second dose can be given. You can look at other values which I've already mentioned, or you can use a low dose tocilizumab where the 80 milligram dose can be initially tried. Then, if eligible, a second dose can be given. So there are two regimes. This is also possible in Kerala government treatment regime. We have already included tocilizumab. This is another experimental therapy. We don't have much data on that, especially this COVID-19. There is a chance of microemboli. The D-dimer levels will be very high. Don't know whether it is because of microemboli or the part of sepsis itself. And there are so many postulated mechanisms from this paper. Here you can see it is because of anticoagulant, anti-inflammatory, endothelial protection, and some antiviral improvement. This can have a slight improvement in SARS-CoV-2. So, even though it is not a standalone therapy, as a prophylactic, a DVT prophylaxis, we can add heparin as well. That also may be having some improvement effect. The lopinavir ritonavir was initially tried. There were people even recommending, claiming that this has cleared the viremia and all. But the recent trial with from China, the Wuhan, were the 199 patients, and it was not showing a significant clinical improvement. It will be obviously further analyzed in a forum, the WHO Solidarity trial, which I've already mentioned. But as of now, the evidence is very weak. Regarding the vaccine, the numerous vaccines initiatives are ongoing. The phase one, the mRNA 1273, the clinical trial has begun. This is evaluating the different doses of vaccine. For total, the 45, the people have already recruited, and different dosages and the antibody response are getting tested at the phase one trial. Obviously, you need other phase two, phase three trial, etc., which will definitely will take more than 6 months time. Lopinavir, ritonavir, I've already told. Ribavirin, this is another drug, not given as a standalone drug, along with interferon. This is also tried. We need more data on that, but it was given in MERS coronavirus, and the same drug was given in Nipah also. The dosage given here is slightly different, where we give a 1.2 gram BD. So another option initially discussed was hydroxychloroquine, lopinavir, ritonavir, along with ribavirin, and another option was to give oseltamivir. But oseltamivir, being a neuraminidase inhibitor, it is unlikely to act on SARS-CoV-2. So there is no point in discussing about oseltamivir, but ribavirin may be having a role. And the Chinese anti-flu drug Arbitol was also tried in the Chinese trials, but I don't know whether this will be available in India. And these drugs will be acting in different mechanisms, including the receptor binding. Our plasma will be acting at this point, and hydroxychloroquine can act in the RNA replication and other sites. So these different drugs will be acting at different sites. So the combination can also be tried, and that is the logic of trying combination. The algorithm proposed, there are different algorithms. Basically, in COVID-19, we have a patient without oxygen requirement, with oxygen requirement, and obviously the severe patients. In the group of the patient with oxygen requirement, there are patients with no risk factors and the patients with high risk factors. In the patients without oxygen requirement and no risk factors, you need only symptomatic treatment. A majority of the patients recovered in Kerala belong to this group and given only symptomatic treatment. And other patients with high risk factors, you can try hydroxychloroquine with azithromycin, again controversial, but obviously giving hydroxychloroquine at that point may not be an issue. But the patients with oxygen requirement, I think we can give either interferon or Convalescence Era. That may be a good option, I feel, along with hydroxychloroquine. We can try giving azithromycin also, but obviously we should be very careful about QTC prolongation. And regarding the interferon, once again, it should be started before the cytokine storm. After the cytokine storm, if you start interferon, it is going to worsen the situation. And in the final arm, you can obviously, like if the patient is having high S score or the features of HLH or like severe cytokine storm, we can think about giving methylprednisolone or tocilizumab or like other investigational therapy, including IVIG. Obviously, we will have to wait more to see like what are the other drugs possible. So to conclude, the lopinavir ritonavir is not very effective. The chloroquine, hydroxychloroquine, there is some evidence, but obviously there is no evidence for prophylaxis as of now. The prophylaxis trials just started. We'll have to wait for the report, but always keep in mind this is a drug with many adverse effects, and especially if you are taking in a huge dose, it can produce cardiac complications. Already cases are reported. And role of immunomodulators, obviously we will have to see at what point the immunomodulators has to be used. Thank you so much. Now, like I will try to answer your queries. Anything related to the management or like the activities going on in Kerala or such things, I will try to answer.
Can I request Sunil to moderate the question answer? Sunil?
Answers now, or can we have it after all the three talks?
No, Dr. Sunil, I have
Okay.
some other work.
Sure. So there are a few questions on the chat. Shall I read it from that?
Yeah, sir, please go ahead.
Yeah. So there is one question on some ulinastatin study. Any idea about its use and your comments on that, Anu?
I don't think there is any data, but even previously, sepsis or pancreatitis, I'm not all convinced with the data on ulnostatin. Obviously, you cannot consider that as a treatment, I feel.
There are a couple of people who have asked you the dose of hydroxychloroquine and azithro. I think I had mentioned, but you can just again repeat that for the benefit of the audience, please.
200 milligram 3 times daily, that is the dose, 600 milligram divided doses for 6 days. But when it is combined with azithromycin, obviously we'll have to look at QTC interval as well.
There's a question on your opinion on hydroxychloroquine prophylaxis. I think you have covered it, but you could just in a single line answer that question.
Hydroxychloroquine prophylaxis, we have clearly told there is no evidence for hydroxychloroquine prophylaxis. Even if you see the ICMR recommendation, they are not even declared what attended that meeting and what is the evidence behind that. And even the WHO recommendation is also not giving any strong evidence for that, and not clear on based on what recommendation they made such a suggestion. So I don't, I'm not personally recommending that, and I don't feel that there is an evidence for that.
Any role for colchicine? There's another question. Have you got any information about the use of colchicine?
Different anti-inflammatory mediators are tried specifically on colchicine.
There is a question on what is your take on remdesivir and how soon you think it may be available in the Indian market?
I don't think the remdesivir will be available in India, because even in US market, I think that is like it is used extensively, and they will not be in a position to export that. I don't think we can expect remdesivir. we can expect the given interferon and the other drugs only. Obviously, the Chinese Arbitron, I don't know whether it will be available in India. If you are trying, maybe that is possible.
Sure. There are a couple of other questions which you have already addressed. Last one is, do you use empirical therapy for suspected COVID cases? What is your...
Already explained, if it is a mild case without comorbidities, only supportive care is enough. If it is a patient with hypoxemia, with comorbidities, without hypoxemia, hydroxychloroquine can be used as a single drug. With hypoxemia, obviously, like if the Convalescence Era is available and the patient is having a worsening trend, before worsening, we can definitely use a Convalescence Era or Interferon before developing the severe cytokine storm. And with the cytokine storm, obviously, we have discussed either steroid or the tocilizumab in selected cases without any other contraindications.
What do you think about BCG vaccine, Anu? On its
nowadays there are so many proposed proposed arguments about why we are not getting much cases in India. So there is some protective factors working in India, but maybe a high temperature. The second may be a BCG vaccination. Other thing considered is the genetic polymorphism seen in Asian population compared to the Europeans. So these are the three proposed mechanisms to explain why there is no why the secondary attack rate in India is low.
Okay, I think we will stop it for now. If there's anything else, we will take it up later. Shall we start the second topic?
Yeah. So good evening. I take this opportunity to welcome the Honorable Prime Minister of Bhutan, Dr. Lothe Tshering. I think most of you must be aware. He is the only practicing urologist in the world, and he himself has taken the interest of listening to our webinar. So probably he might have some queries, but I would like to personally thank him for his presence and welcome him on behalf of ACME and from the country India. Thank you, sir. Now we move. So Dr. Lothe Tshering, do you have any questions? Do you wanted to? I think Vinay, you have to unmute yes. Dr. Tshering.
I have unmuted him, sir. I have unmuted.
Dr. Tshering, can you hear us? Do you have any queries, sir? I think it's still not. Yeah, I think he's trying to talk. Hello.
Is he unmuted?
Yeah.
Yes, sir.
Sir.
All right. Then let's continue. When he's coming back online, we can try to take his question. So now I request Dr. Pradeep Rangappa sir to present his updates on the latest articles. Over to Dr. Pradeep.
Good evening, everyone. So hope I'm audible to everyone. So I'll be talking on this seventh update on COVID. So I've already covered the past journal articles in last 6 updates. So this time I would be talking about the 3 articles. I think as you would see, there is a lot of noise coming from various journal articles. So it is extremely important to identify what is most pertinent for us to discuss. So I think the slides are not moving, Vinay. So is there a way? Slides don't seem to be. Yeah. Okay. Sorry about that. So we have a lot of articles coming in. So the way I would identify a good article is not to miss out the ones that feature in top journal, impact journals like NEJM or Lancet. because otherwise you would have a lot of small articles coming in various other journals by various authors from different countries. But it is important to identify the articles coming from the peer reviewed from the top journals. So that's what I've tried to do in every journal update. So the journal article I picked up this time is the NEJM article. I think the backdrop of this is this WhatsApp message that came in.
Sorry to interrupt. Your slide is frozen, sir.
Oh, is it? Okay. So is it moving now, Vinay?
No, sir. Could you reshare the screen, sir?
Okay. So I do a escape and reshare, is it?
Yes, sir.
So should I stop share?
Yes, yes, sir.
Is it moving?
Yes, yes, no, sir.
Okay, so sorry about that. So the backdrop of the article I picked up is this particular WhatsApp picture that came to see the allocation of resources that has happened. So this is, you see the doctor here who is, not having protective equipment, personal. So he's putting a handkerchief without a glove. But you see the other people, the security and the VIPs having glove and a N95 mask and others. So it is extremely important, friends, that we need to clearly understand what allocation of resources mean. So I picked up this journal, which is very important now, considering that there is going to be a lot more cases that will be coming to the hospitals and to the ICU. So this came in NEJM, as you see, on 23rd March 2020. It's a fair allocation of scarce medical resources in the time of COVID. So what is important is to know the historic background. So historically, it is shown that during epidemics, there needs to be rationing of certain medical services that we offer and the interventions that we provide to the patients. So if you look at the US, so they are already claiming there is shortage of N95 masks, and they are contemplating on reusing the N95 mask, and they're looking at strategies to reuse N95 masks. And in Italy, they are prioritizing the allocation of ICU beds and the ventilator to the patients who would benefit most from these resources. So already this allocation strategy has started in countries where there is explosion of cases. And in UK, they have a strategy of downgrading personal protective equipment, so which has been heavily criticized by the various authorities. So this whole article looks into how we can, ration these medical resources and how it can be accommodated fairly. So they come out with 6 recommendations. It is important for every doctor listening to this to understand how we rationalize our resource allocation. I think that is what this whole article talks on. So I would urge all the healthcare administrators to read this article. So if you look at the difference between the influenza and COVID in the US data, so you see the red box. So you would see when moderate COVID strikes, I think the number of patients that would be admitted to ICU would be staggering 960,000 people, around close to 10 lakhs. And if it is a severe COVID, the number of ICU admissions would be 3.8 million. So this is the projected figures in US, which is an alarming number. And if you look at the number of deaths in US, if the COVID strikes them severely, it will be close to 2 million. So which is really, really worrying trends and the projected trends that they have described in this NEJM article. And we have seen this figure multiple platforms that there is one patient who has a potential to infect 2 to 2.5 people. And when that happens, so you have this reproductive number. So in 30 days, around 406 people would be infected. So if you extrapolate, so around 5% of the population could get affected in 3 months. So that is the alarming rate at which one individual, if he is allowed to infect, he can literally lead to 5% of the population getting affected and multiple people participate in spreading this infection. So that is why it is extremely important as to why this quarantining that has been adopted in our country is terribly, terribly important at this point of time. And let us, so this NEJM article does look into the Chinese data. So when we look at Chinese data, what is very clear is 80% of the COVID-19 patients are asymptomatic, or they have very mild symptoms. They're ambulatory. They don't need ICU hospital admissions. So that is a good number for us to have in back of mind, which means 80% when they stay at home quarantined. So we have a good ability of them not spreading the infection in the community. And the advanced healthcare services, which means the hospital care is needed only in 20% of the patients, and 15% of them will have severe illness, and 5% is what the figure we would be looking at in worldwide who would need critically ill beds. But this data is little different to Italy, because Italy it's more than 10% are needing ICU. But I think we can subscribe to this figure in our country, only 5% would need critical illness. So the mortality from the Chinese data is 0.25 to 3%. And it is shown to be higher in elderly people, and where mortality can be more than 14%, or patients with a lot of comorbid problems. So 10% of cardiovascular disease and 7% with comorbid of diabetes had a higher mortality. And it is clearly shown that the mortality is in COVID is higher than seasonal flu, where seasonal flu mortality is only 0.1%. So this is the backdrop as to what is the number of cases that would possibly need our ICU admission. So it's around 5% is what, if you look at it. So this they have extrapolated to the American data. So the American Hospital Association, so they have looked into their own country database, and they realized that they have 85,000 ICU beds, and they have 62,000 full-featured ventilators, and they have 98,000 non-full featured. But what they have realized is what is extremely important is the manpower. Because to operate these ventilators, you need skilled doctors, respiratory therapists, and nurses 24 hours, 365 days, which means in 3 shifts, you would need this sort of a manpower. And remember, when COVID-19 strikes, some of these nurses and some of these doctors may be quarantined, or they may get ill and they may absent themselves. So there would be a tremendous sort of a pressure on optimizing our manpower or to operate these ventilators, which is a serious concern. And American Hospital Association, they realized that there would be an impending shortfall of personal protective equipment in any sort of a pandemic or epidemic the type we are dealing with. So this is something which every country should be geared for. And that's what I think in India we are doing. So every hospital, every state, they are putting enormous resources to try and optimize this stacking up of personal protective equipment so that we don't fall short. And most importantly, amidst all this, Anup has spoken about all these good drugs, hydroxychloroquine, lopinavir, favipiravir. See, again, when our disease explosion happens and when there are more sicker, like 15% get admitted to hospital, the requirement for this drug also starts increasing. So there will be a cascading increase in the requirement of these drugs, and production of these drugs also does take time, and that may also impair our optimization. So I think the whole strategy, even this NEGM paper talks, is we need to adopt very stringent public health measures so that we buy time, so that we have good lag time to do all these preparations, to optimize ventilators, to optimize ICU beds, to optimize personal protective equipment, to optimize the drug reserves. The public health measures have to be adopted in every country, and I think that's why our honorable government in India has adopted this. So basically adopting this basic innate public, keeping safe distance, washing hands, working remotely, avoiding crowds, stay at home like we are doing a webinar, no handshakes, and cough etiquette. And even there is a new data coming from different countries saying wearing masks. I think I find extremely good. I have to applaud our Karnataka police and government who are enforcing that everyone wears a mask, which is very important because it is being realized that the burden of this disease can be minimized by simply wearing a mask, whoever ventures out of the home. So this also is a simple steps which has shown remarkable difference. So like there was a report from Czechoslovakia where they found, Czech Republic, where they found significantly reduced, they could flatten the curve by just using masks wherever they went. I think what this all enables us to give adequate time for us to prepare ourselves. Even when the curve flattens, we start getting a lot of cases, there'll be adequate preparation in place. And I'm sure every listener on this forum knows that they are preparing at their best to make sure that they have put all the processes in their place. I'm sure no one in India is sitting quiet. Everyone is putting in their best efforts to prepare themselves for these cases, which may start swelling over the course of time, is what we are foreseeing. But our prayers remain that it doesn't swell as much as it has in other countries. So what are the recommendations this paper makes? So obviously, whatever recommendations that we make on rationing the services should encompass ethical principles, isn't it? So the first one they say is our intent should be to save maximum lives and improve the prognosis. So that receives the highest priority. And another thing they say is when you have two patients with a similar prognosis that come in, so we need to use this random selection, which again one can debate and argue. So they sort of desist from saying first come first served should not be the way to go. So this is extremely important. I think this particular thing I want all listeners to pay attention. So this article emphasizes even from ethical standpoint, priority should be given to the patients who have significant contribution to the society, and that should be rewarded. They call it as an instrumental value, and all healthcare personnel fall under the category of this, where they are of huge instrumental value. And if you see the underlining I have done, you have to give priority to the healthcare workers if you have to choose between 2-3 patients, and this comes from the ethical standpoint from this paper. So that is something which is good for us to impart to all the people around the administrators, especially in any sector, so that healthcare workers are given priority when care has to be delivered, when hospital care has to be given or ICU care has to be delivered. So this message is important for every intensivist who is logged in today, that priority has to be given to healthcare personnel over anyone else when they come sick to our ICU with possible COVID. I think that is a good message that you get from this paper. And obviously, we choose young patients who have a good ability to recover over the elderly patients. So they come out with these 6 recommendations. The first recommendation is they call something as resource stewardship, which means our intent should be to save more lives, but more lives with good quality so that they are productive. So maximum length of life is what should be. And we should encourage during this course of time an advanced directive. So if you have an elderly individual with a lot of comorbidities, with end-stage organ dysfunction, who may not really have a good chance of recovery, so we should work towards having an advanced directive for such patients, or if they have an express wish, we should adopt it. And we should emphasize on patients who are likely to recover than a patient where we know for sure that whatever measures we put in place, their recovery would be very unlikely. And withdrawal in a patient where multi-organ failure has set in, where continuing ongoing measures would be futile. I think withdrawal is something that we should be adopting. I know that these are all debatable issues in India, but I think it's a good paper to have some clarity on all these aspects to optimize resources. So the second recommendations the authors make is the intervention. So when the 5% of the population who may need these advanced interventions like ICU beds, ventilation, testing, again, clearly recommendation 2 says that we have to give absolute priority to the healthcare personnel, be it doctors, be it nurses, be it respiratory therapists, and they are considered as people with instrumental value during these epidemics or pandemics. And this will also encourage, if their healthcare is well protected, and you would be optimizing your healthcare pool so that the care to the patients will be optimal, and it can be better optimized. Because if you're not caring for them, they become more sicker, then obviously you'll have issues with absenteeism, and you have less healthcare personnel who can deal with the sicker patients. So I think this is the point. I think from this paper, I really need to emphasize that priority across the board. It doesn't matter if it's corporate hospital, so across the board, government, all hospitals who are dealing, I think the priority has to be reserved for this, because that is ethics, and that is conforming to the ethical principle. So the recommendation 3 is, if you have 2 patients coming with COVID with similar prognosis, this paper suggests that random allocation of some sort of and they even suggest it could be a lottery sort of a random, and they do desist from giving preference to first come first served. I know you can debate on this. The reason they say that is, if you adopt this first come first served, then even the less sicker patients would rush in and claim that they need admissions, as opposed to another patient who may be delaying his presentation. So I think we wouldn't go too much, because I don't know how much would that be applicable in our country. So the 4th recommendation is they talk about prioritizing guidelines, which means the guidelines are fluidic. So they suggest that guidelines are not rigid. So as I said, these guidelines are evolving. So even these guidelines has to respond to the changing scientific evidence. See, every day, I think there's so much of noise, so much of literature coming from on this COVID. It is extremely hard for us to rationalize what is right thing. What we think is right thing today may not be the right thing after a week, because the evidence is so rapidly changing, and the type of experience also is fairly different from the China and from the Italy and from the Spain or USA. So things are very different. So our guidelines also have to be fluidic, and they should change with changing scientific evidence. And in recommendation 4, they say, they give an example. Suppose if a vaccine comes out, the suggestion is preference has to be given to elderly because vaccine is more preventative. And the argument they make is the younger individuals have a better ability to develop herd immunity, and that may be more protective. Unless you have shown epidemiological modeling saying that a vaccine has to be given in younger people to prevent the spread, then it's a different issue. So these are all little nebulous points, but authors keep giving examples to justify that, why vaccines should be, preference should be given to elderly. And recommendation 5, I think this is also important. If any of the patient is enrolled in a trial, suppose ICMR is doing a hydroxychloroquine trial, and if a patient is enrolled, and he should be given preference for all the services, and because he becomes instrumental value. So any patient who is involved in the safety and efficacy of the vaccine or the drug trials or participates in any research that a organization or ICMR is undertaking, so that patient will be given preference. So this is also a very important point for listeners to bear in mind. And this is the last recommendation, which is very important. So again, in the zeal and in our overzealous enthusiasm to treat COVID-19 patients, we cannot forget the other patients. So I think there is no difference when we are trying to stratify. The ethical principle still remains that which patient maximizes or has an immense benefit from the interventions that you do is the one who should be given preference. So the example the authors give for this recommendation 6 is, if you have a COVID-19 young patient sitting in the hospital, sitting in a ER, and you have a young healthcare personnel coming with an anaphylaxis to an allergen, so the preference has to be given to an anaphylaxis because definitely the chances of improving and survival is much better, and the instrumental value of that individual is more. So these principles are something that they suggest that we need to adopt. So the conclusions this paper makes is, the first statement the paper makes is, yes, government should take all measures to prevent scarcity of any of these medical equipments and medical interventions that we need to adopt. I think our Indian government is doing fantastic in that they are really mobilizing all the personal protective equipment. They are preparing COVID hospitals across India. I think these are all fantastic steps which exactly resonates what is coming out from the paper. And if we fall short, even despite all this preparation that nature has blessed our country with at this point of time, we feel we still fall short and we have scarcity, then we need to adopt this recommendation. Based on these 6 recommendations, we need to come out with guidelines and adopt these guidelines. So that is the gist of this paper. So again, the 2 points I want listeners to have absolute clarity is that there is a good ethical sort of a substantiation that preference has to be given to all our healthcare personnel if they become sick. That is one. And second thing is, I think you have to rationalize as to which patient would benefit from the care that you are giving and adopt and care for that patient rather than taking care of another patient where that the chances of his survival would be poor. So I think those are the rough sort of conclusions that we can make from this paper. I think this picture typically denotes what has been happening in our country. Like, we're all really fighting to, fighting for our country against this wretched virus. But there are obviously some elements which have created certain obstacles for us. So we need to forget all that, and we need to continue to strive to fight against this virus. So I think I'll just take another 5 minutes to very quickly talk about this small little paper. This came in Lancet. I think this is also very important, again, touching on the basics of what we should be doing. See, this also talks about the percentage. It talks about essential care of critical illness must not be forgotten in the COVID. So this is a very good one-page article. So again, they say 80% they do not need hospital care, so you can forget. So this quarantine and social distancing should take care of this 80%. But what we will be dealing in our hospitals is this 15% and this 5%, right? So this paper emphasizes on caring well for these 15% so that they don't spill over in our 5% and overburden our resource burdening ICU. So this is what this paper recognizes. And the example they gave is, I think they relate to Malawi, where 89% of the hypoxic patients with saturation less than 90% were not given oxygen, and 53% with low GCS were not put in supine or no airway. So what authors are trying to resonate is simple steps can prevent this 15% spilling over to ICU. So this paper is all about what are the simple steps that we can take. So the emphasis is on low cost essential care. The simple things you can do is keep your hospital ready for any potential, which I'm sure all the listeners are putting immense efforts in preparing your hospital to be ready to tackle this menace, and adopt your strategies of good quality clinical practice in identifying, having a high index of suspicion in identifying patients with COVID and giving good clinical care for these patients. And the second most important emphasis, which is low cost, which does not involve a lot of cost, is having an effective triage system within your setup. I think I'm sure every listener here would have strategized some sort of a triaging in their own hospital. And third most important, which I'm sure all our WhatsApp forums is filled with this, how to stack up or how to optimize our personal protective equipment care. And our topmost priority is to ensure absolute safety of our healthcare personnel by having all the personal protective equipment. I'm sure every doctor, as I see in every forum, is putting in their best efforts to make sure that they have enough of personal protective equipment. And so does our government, because when you see a press release from our Honorable Health Secretary, every time there is a mention that they have put in a lot of efforts to get PPEs from indigenously manufactured here and from outside as well. And the simple thing what every hospital can do is have their own protocol, which is user-friendly and concise, which suits their state or their area where they would work. So have a simple user-friendly protocol, which is percolated and disseminated to all the healthcare personnel dealing with COVID. And and I think there is a good emphasis. I'm sure many of my Bangalore friends who have worked to, have given inputs to the government would agree with me that a lot of importance has to be given for oxygen, simple oxygen, because that 15% of the patients, low essential care, they only need oxygen, and there should be an uninterrupted supply of oxygen, and that should be optimized is what this paper emphasizes. And this paper emphasizes on simple measures, like if you have a COVID who is hospitalized, please maintain simple head end elevation or propped up position, good suction and good chest physio. These are simple, low cost essential care the authors subscribe to, as which can have a huge influence on reducing mortality. Most importantly, to prevent these patients to heading into other organ dysfunction. And all together, our intent is to reduce the burden on our ICU capacity. Simple things, have uninterrupted, have this triaging, have hospital readiness, good protective, personal protective equipment, and uninterrupted oxygen supply, and simple fast hug principles, which every intensivist know, and try to see how effectively we can minimize their spilling over to ICU. So this is all about this particular paper. Very simple, but very strong message that our whole aim is to identify this 15% and prevent them from spilling over into our ICU. And I think this is the flow chart that they talk. It's again the summary of whatever I said. So correct use of oxygen, triage system, oxygen source. So all this has a bearing on survival of the patients. And I think this is just a single slide. It is from Dr. Devadasan from India. This is floated in WhatsApp. It's an excellent analysis, epidemiological analysis of how India is heading. So if you look from day 1 to day 28, if you see the curves in the Western countries like Italy, Spain, France, UK or USA, these curves are really exponentially taken off after, after 2 weeks. So if you see, so they have identified a factor. So Indian rise, if you see, Indian increase has happened with a factor of 1.45. But if you look at Italy, it happened with a factor of 198, which means we are really winning this at this point of time. The steps taken collectively by our medical community, by Honorable Government of India has been fabulous at this point of time, because our increase has definitely stupendously better compared to these countries. But we don't know still, we may still have an issue with this curve taking off. And as you see, it is slowly raising its hood. So I think we need to take all the efforts to make sure that this doesn't happen. Okay, and I think this is only two slide study, very small article which came from Gattinoni. It came in American Journal of Respiratory on 30th March 2020. Basically, this Gattinoni, I'm sure every intensivist hearing to this webinar would know who Gattinoni. He has put a lot of work on ARDS and lungs. So he did a small observation in 16 patients, and he found that the COVID-19 ARDS is very distinctly different to the conventional ARDS that we have been dealing with. I think this is also, we have extensively discussed in various platforms. So what he found is respiratory compliance of these patients is somehow found to be very good. It's 50.2 plus minus 14.3, which is a good compliance in unlike ARDS where you would expect a much lesser compliance. But this was disproportionate to the shunt fraction, which was 0.5, which and the physiological basis that Gattinoni mentions in this paper is the lung perfusion regulation is something that is impaired in COVID lungs. So this is what he mentions. And there is a vascular issue. There is a hypoxic vasoconstriction that is leading to a big ventilator perfusion mismatch sort of a situation. And that is leading to hypoxia is what the hypothesis that is generated in this paper. And this is the graphical representation that compliance is good and the shunt fraction is very small, which is very disproportionate. So it's just a one-page article, one-page or two-page article. So the conclusions the Gattinoni makes, or rather he just highlights that there is a possibility that when patients are putting increased work of breathing, the increase in intrathoracic negative pressure possibly could lead to self-inflicted lung injury. So this is a hypothesis that he makes from the observations because of the disproportionate compliance and the shunt fraction that is prevailing. And when you use high PEEP like we would conventionally use in an ARDS, where the recruitability of the lung is questionable, so it can lead to, because you're giving high PEEP, so it has the deleterious effect of this may be manifested with hemodynamic impairment in the setting of myocardial dysfunction that is known to occur in these COVID patients with fluid retention. And when we go on to prone, where compliance is very good, but you're proning to circumvent the hypoxia, so the benefits may not be huge. So this is the conclusion. So I would say it is still hypothesis. So we need to derive observations from our Indian experience and see whether our Indian patients do manifest with this increased compliance. Because I got some reports from certain people who have treated ventilated patients in India saying compliance was good. So we need to make recordings of these compliance and see whether they are behaving differently to the conventional ARDS. So I'm sure this is a WhatsApp you've been seeing. So I would end my presentation with this to sum up. Somebody ate something in China and the entire world is washing. I'm sure this WhatsApp message you've been seeing. So thank you very much. I'll give it to Sunil to moderate and then take it to the next session. Thank you very much.
Thank you, Pradeep. Thank you, Pradeep. I think there are not too many questions pertaining to your topic specifically. A couple of general questions on ER protocol and things like that. I think we'll take it up as a part of the panel if it's okay with you.
Yeah, sure, Sunil. Go. I'll mute myself then.
Yeah, sure. So Raja, let's move on to the third talk. Dr. Ajit, I think, can take over. Raja, are you there?
Yes, I've unmuted Dr. Ajit. Yes.
So can you hear me? Can you hear me?
Yes, sir.
Yeah. So I can start, is it?
Yeah, please unmute me, Vinay.
Yes.
Yeah. So good evening. The topic is, the handling of dead bodies of COVID patients. So this become important when you have a suspected COVID patient or a COVID patient who passed away in your ICU, and you need to know what is to be done for what are the precautions to be done for this. It is not moving. It is not moving.
Yes.
So yeah, thanks for that. So basically, there is lots of resources are available because this discussion that is predominantly based on the Government of India guidelines, Ministry of Health and Family Welfare guidelines. Obviously, there is another guideline which has come from the All India Institute of Medical Science in New Delhi. There is an international Chinese Hong Kong guideline is there, and there is a European Center for Disease Prevention guideline is also there. But to avoid any kind of a crisis any kind of confusion in this crisis, I believe that it's better to follow or discuss the Government of India guideline, which is in essence of all the whatever the guidelines that we have already mentioned here. So obviously we know that the predominant mode of transmission of COVID-19 is through droplets. So basically we know that the dead body is never going to breathe or sneeze. So naturally, unless you're dealing with the respiratory secretions, you are very, very unlikely that you are going to get infected. There is no increase in chance of infection of the dead body. That is one thing we all should know. Only the lungs of the dead COVID patient, if handled during the autopsy, can be infectious. So unless you dissect the lung, it is very, very unlikely that the dead body per se is going to be highly infectious to any of these patients, any of these relatives or healthcare workers. So basically, if you look at the Chinese guidelines, basically, there are 3 risks are there. Basically, category 1, the risk of infection from the dead body to the healthcare workers and bystanders. The category 1, category 2, and category 3. And obviously, you can see that the coronavirus comes to the category 2. In category 2, what is happening is that whenever you deal with a dead body, you need to take the standard precautions and additional precautions. Unlike, the category 3, where, like anthrax, plague, rabies and all, you take the standard precautions and stringent precautions. So what I mean to say is that the corona thing that is belonging to the category 2, where you need to take the standard precautions and, some additional precautions, which we'll be discussing. So basically, whenever we deal with that, one of the most important thing in these kind of patients is that we need to train the staff for the infection control practices. This is very important. We all know all the staff identified to handle dead bodies in the isolation area. That is the ICU, where the patient must have passed away. Your native patient room, the mortuary, the ambulance workers, and those workers in the crematorium. So some of the, in India, few people go for crematorium. Many people may be going for burial ground. They should be trained in the infection control prevention practices. This is very important. And obviously, all the staff need to take the standard precaution, which I don't want to read out everything. The hand hygiene, use of routine personal protective equipments, including a water-resistant apron, gloves, masks, etc. I'm not reading out that. All the standard precautions need to be done. And in any patient, what I want to give the message is that any personnel who is standing with the dead body from the time of death to the crematorium is that no personnel should, absolutely, there is no smoking is allowed, no eating and drinking is allowed, obviously, because this is going to breach the, the infection protocol. No touching of the nose, mouth and eyes. We know that, most of the time it's a droplet infection or respiratory secretion which is infecting when the mucous membrane of the nose, mouth and eyes are involved. So there is no touching of the nose, mouth or eyes are, allowed in any parting of in any other person who's involved during this, from the time of death to the full, cremation is over. I mean, to the burial. And we'll start from the handling of the dead body, from the removal of the dead body from the isolation room area. So the patient is dead now, and you are in the ICU. You want to remove the patient from the ICU to most of the time, we remove most of the time we give to the mortuary. Some people maybe directly take it to the handling of the relatives, which I'll be just discussing that. So in the mortuary, in the isolation room, the healthcare workers attending the dead body should perform hand hygiene, ensure proper use of personal protective equipments, water-resistant apron, goggles, N95 masks and gloves. What I mean to say is that whenever the patient is dead in the ICU, patient is in the isolation room, those healthcare workers, the doctor, but number one is that we need to reduce the number of healthcare workers attending. The doctor, or maybe the AYA, who is attending you. It's a must that the person who is dealing with the dead body at the bedside obviously need to wear an N95 mask along with other personal protective measures. All the tubes, drains, and catheters of the dead body should be removed, which we are doing, and all the puncture holes on the wounds resulting from the removal of the catheters should be disinfected with 1% hypochlorite and dressed with impermeable material. So naturally, just like any other dead body, we remove all the lines, drains, and all these areas will be oozing. So naturally, these areas you need to disinfect it with 1% hypochlorite, which has already mentioned in the Indian guideline. Apply caution while handling sharps such as intravenous catheters and all that. We all know that. Plug oral nasal orifice of the dead body to prevent leakage of the body fluids. It's very important because obviously the respiratory secretions are likely to be infectious. We need to see that, like we all do for most of our patients. We plug the oral and nasal orifices of the dead body to prevent the leakage of this one. That we'll be doing that. If the family of the patient wishes to view the dead body at the time of removal from the isolation room or area, he may be allowed to do so with the application of standard precaution. In this situation, if at all we allow the person, the relative, the dear and near one to see the dead body, so he can be allowed with the distance. Obviously, if he's going too closer, less than 2 meters, then he need to have a PP with an N95 mask. But obviously, if you want to allow the person for a distance, 2 meter distance, with the mask and the mask, gloves, and a water-resistant apron, you can still allow the relative to see the dead body from a distance of 2 meters inside the ICU before he shift to the mortuary or hand over the body to the patients or relatives. So what we do with the dead body is that naturally, when you process that, when you remove the drain, when you disinfect the body, we need to put that body in a polythene container. So the polythene container is usually what has been recommended in international guidelines are you need to use a zipped container to avoid any confusion and all, to provide any kind of a leak from anywhere. You should have a contained in a polythene container with a zip has to be there. The exterior of the body bag is decontaminated with the 1% hypochlorite. So once you put the person in the zipped polythene cover, in the international guidelines say that this cover should be at least around 150 micron in thickness. 150 micron thickness has to be there. When you put the dead body into that, after you zip the thing, then this polythene cover has to be disinfected with a hypochlorite, 1% hypochlorite bag has to be done. Then afterwards, this has to be wrapped with another sheet called mortuary sheet, or the Indian guidelines are telling that the sheet provided by the family members. So one thing I want to say, reiterate is that no pins are allowed. Obviously, because it should be ideally closed, zipped in a plastic cover, because you cannot have any kind of a pin and all. Obviously, leaking is going to happen. No pins are allowed. You do the polythene cover thing. You disinfect it in a 1% hypochlorite. Then you put it in another, mortuary sheet or another sheet provided by the relatives as per the Indian guideline. The body will be either handed over to the relatives or taken to mortuary. What I mean to say is that most of the Indian experts strongly believe at this point of time that it is not proper, at least as per the Indian customs, though the people prefer to, bury their dear and near ones in their own neighborhood, it should not be allowed, because the handing over the dead body can happen in hugging, kissing, and all these sort of emotional, exercises. So it should be strongly discouraged, and ideally the dead body has to go to the mortuary. Sorry. And obviously after we remove the dead body, all the equipment should be autoclaved and all. Because of time constraint, I am not going to read out everything. So naturally, once you send the dead body to the mortuary, obviously the area where the dead body has been there, all the cords, everything needs to be cleaned. All the surface of the isolation area, floors, bed, railings, side tables, IV stand, etc. should be wiped with 1% sodium hypochlorite solution with allowed a corner time of 30 minutes and then allowed to dry. So after we send the bed, after we put it in the polythene cover and shift the patient to the mortuary, these cords and all the patients around need to be again cleaned with 1% sodium hypochlorite. And the Chinese guidelines are slightly different. They are giving 2-3 different strengths of sodium hypochlorite. For example, when the surfaces are visibly contaminated with blood and body fluids, there should be 1 in 4 diluted household bleach, mixing 1 part with 50 parts of 4 parts of water. This is more concentrated when you're dealing with the blood and body fluid. In other areas, it's only 1:4 proportion. Here it is 1:50 proportion. Here it is mixed in 1:4 dilution when you have a strong blood and body fluids are there. And some of the Chinese guidelines are telling you can even use putting a washing machine, the linens and all. It can undergo a hot washing cycle more than 70 degrees. And obviously when the patient is the mortuary, obviously it needs to be handled properly, because I may not be dealing much with that, because most of the crowd is we are often in intensive care. Obviously the forensic medicine expert will be knowing that. The mortuary staff handling the COVID-19 dead body should be observed the standard precautions, which we already mentioned. Dead body should be stored at cold chambers, maintained at approximately 4 degrees centigrade. The mortuary must be kept clean in a clean environment with the clean environmental surfaces. Instruments and transport only should be properly disinfected with 1% hypochlorite solution. Even those things need to be done. And after removing the dead body, again all these areas, handles, everything needs to be cleaned with 1% sodium hypochlorite solution. So what I mean to say that once a patient is the mortuary, one major message which I could get from the literature is that embalming should not be allowed in this kind of cases, because obviously when the skin is when the surface touching is involved, there is increased chance of infection is there. Obviously my key message is that embalming should not be allowed when a COVID patient or suspected COVID patient is dying or dead. And another thing is that autopsy should be strongly discouraged. We cannot allow for the autopsy to happen, because as I mentioned to you, because autopsy, if at all we are doing, you need to do in a negative pressure room. The expert needs to be there. Obviously, the number need to be restricted. It is going to be more cumbersome to do the autopsies, because lung resection is one thing which can increase the chance of an infection. So in this case, unless there is a strongly compelling reason, the autopsy should be avoided in case of a COVID death or suspected COVID death. But that's what I want to highlight that. And the autopsy part, and I'm just skipping the slides because obviously whenever you are doing that, you need to have the mortuary also have to have a native pressure isolation room. I mean, room has to be there in mortuary as well. And once the autopsy is over, or even if you don't do the autopsy, when you transfer the patient, the body, secured in a body bag, and which is again decontaminated with a polythene cover process. No additional risk to the staff transporting the dead body from the mortuary. There is no additional risk is there. Patient is in a zipped polythene cover, which already mentioned. There is another cover is also there. The polythene cover, which I already mentioned to you, it is already disinfected with a 1% hypochlorite solution. The person handling of the body may follow the standard precaution I told you, because whoever is touching, they don't have to wear N95 mask. They can wear a routine, maybe a apron, maybe a mask and gloves they can wear. The vehicle after which the transfer, the cremation or the burial staff. If you are taking the dead body, obviously we promote, taking the dead body, the cremation or the burial ground. So the cremation, the burial staff will be the transfer of the burial staff. What's happening? The vehicle that also needs to be decontaminated with 1% sodium hypochlorite. So basically, now the patient is shifted to the mortuary. I told you that transport vehicle has to be disinfected with 1% sodium hypochlorite. And the crematorium, these are the precautions. The crematorium and the burial ground staff should be sensitized that COVID does not pose additional risk, which already we have mentioned. The staff will practice standard precautions of hand hygiene using mask and gloves. Obviously, the standard hand hygiene has to be practiced. Viewing of the dead body by the unzipping of the face end of the body by the staff using standard precaution can be allowed for relatives to see the body for one last time. So if you have a zipping system, is zipped polythene cover is there, maybe you can just unzip the thing. Without you can allow the relative to see the body without touching the body, by using the zipping system for the polythene cover. In the religious rituals such as readings from the religious scripts, sprinkling of holy water, which is not uncommon in India. Any other last rites does not require touching of the dead body can be allowed. What I mean to say is that without touching of this, religious chanting can be there. Even we can use sprinkling of holy water can be allowed. Bathing, kissing, and hugging except for the dead body should not be allowed. So we already mentioned that. So no bathing is allowed, no kissing is allowed, no hugging is allowed. I want to again reiterate that most of the Indian experts, including many from the ISCCM, strongly believe that a dead body should not be handed over to the relative, at least in these COVID cases. It needs to be promoted. It needs to be cremated in a burial ground, preferably in a crematorium. Obviously, we don't have that much facilities all over India, at least in a burial ground. It should be handled with specialized staff in the burial ground or in the crematorium. Again, as I mentioned to you, the danger of infection is coming to category 2, which I already mentioned. And, obviously, with all these, predominantly what I read this out is predominantly from the Indian guideline. There is some kind of a refinement has been, obviously, like any criticism there, some kind of refinement has been proposed by many organizations. Again, which I told you, the polythene bag, the Indian guidelines has not mentioned about the polythene bag, but the Chinese guideline clearly mentions that the polythene bag with which the dead body is wrapped should be at least around, at least should have a thickness of around 150 micron. And if you talk to me, if you ask me, the best way to disinfect would have been to send the patient to the crematorium, the dead body, cremate the dead body in the crematorium. It should be electric crematorium or a compressed natural gas crematorium, which would have been the preferred method. And another recommendation is that it should be kept at least around 6 to 8 feet below the ground with immediate cementing over the graves, because obviously the Indian guidelines has not mentioned that. Some of the experts believe that, obviously it cannot be in a shallow place. Obviously, if at all you bury the dead body, it should be at least around 6 to 8 feet. And these areas, the grave has to be cemented immediately. That is some of the proposals or some of the refinement which has been proposed to the current guidelines. And the body should never be handed over to the guidelines. It never be handed over to the relatives, has been strongly recommended by the Indian expert at this point of time. So my take-home message is in 2 slides. Droplet spread is a key method of spread by COVID-19. The spread from the dead body is almost impossible if adequate precautions are taken. The COVID-19 is classified as a category 2 for the risk of infection. All the healthcare-related staff, including doctors, nurses, housekeeping staff, mortuary staff, ambulance team, and funeral operations, need to be made aware of the precautions and should be trained regarding the handling of the dead bodies. All handling staff, I believe that at the time of the patient is dead in the ICU, the patient is passed away in the ICU, you do the handling staff unless and until the body is put in the zipped polythene cover and plus the mortuary, plus the polythene cover, plus the mortuary sheet. Till that process is over, unless and until you put the body in the zipped polythene cover and you disinfected the polythene cover and then you put it in the mortuary sheet, till that time you need to have all the standard precaution. Plus, you should have an N95 mask has to be there. And all other thing. Once the zipping, I mean the wrapping has happened, and it's in another mortuary sheet. 2 covers are already put. Then after that all the staff who are involved, including the ambulance staff, the crematory staff who are touching the body, they need to, or very near to the body, handling the body, should wear mask, gloves, and routine mask, gloves, and aprons. Handlers are never allowed to eat, drink, or touch their nose, mouth, and eyes at any stage. I already mentioned any stage. And embalming is not allowed. We already highlighted that. Autopsies are discouraged as much as possible. Unless there is a compelling reason to do an autopsy, it has to be strongly discouraged. It should not be done. If at all we are doing, again, it has to be done in all these, all native press rooms, and all these things need to be there. No bathing, kissing, or hugging by the bodies are allowed. We already, multiple times we have discussed that. It is ideal not to hand over the dead body to the relatives as much as possible. We already mentioned that. It would have been ideally cremate the bodies at electric or gas crematorium. We already mentioned that, because that would have been the best way to infrastructure control. Though still it is not very conclusively proved. But obviously many experts believe that the best way to disinfect will be to put in a crematorium or a electric crematorium or gas crematorium. Thank you very much for your patient listen.
Yeah, thank you, Dr. Ajit.
I thank all the speakers for their excellent talk. So we'll move on to the panel. There are a few questions which I thought we will take it at the end of the session, if it's okay with you, Raja.
Sir, I once again wanted to welcome Dr. Lote Shering. I think he is now connected.
Okay.
He had 1 or 2 questions, if he can just narrate, or maybe if he wants to talk to us. Dr. Lote Shering, we welcome you on behalf of entire India. It's good to have you out over with us. We have all the senior most intensivists connected in this platform. We have Dr. Pradeep Rankappa, Dr. Yash Javeri. We have Dr. Rajesh Mishra ji, Dr. Dilip. Many of us are connected. So if there is any specific question which is pertaining to Bhutan or something else in your mind, you can feel free to let us know, sir. Hello.
We can hear him, Raja.
I'm also not able to hear him, but he's online.
I don't think we can hear. Can you, Pradeep?
No, I heard in between message. I thought it must be him.
Yeah, there was a message from him. In fact, he has dropped a message. I believe Dr. Dilip has already answered that. Okay, maybe any time if you like to once again talk, you can always talk, sir. So we go on to the panel discussion.
Yeah. So is it okay? Can we take all the other questions in the end, because some of these questions will probably get answered in the panel?
Yes,
Yes,
absolutely, Sunil. Absolutely.
Yeah, and we'll try to keep about 3 minutes, 2 to 3 minutes per question, because we have around 10 or 12 questions, and maybe a few from the audience as well. So my first question will be to Dr. Rajesh Mishra. It could be a little bit of a repetition, but I think it will be good if you could, with your national experience, Rajesh, emphasize on that. What are the infrastructure requirements that will be needed for a medium-sized hospital, and also probably tertiary level hospital, with the current levels of prevalence that we have in a community? This is primarily to get people prepared for the current scenario. I would like some words from you and some thoughts from you about this. Rajesh, are you there?
Yeah, I'm there.
Yeah.
And they can listen to you. Go ahead.
I just divide the answer into 2 parts, more addressing the medium-sized hospital and perhaps a large referral hospital. What do you think they should be ready for in the current scenario, with the current prevalence rate, assuming that things don't get worse as we go forward?
Sunil, if we go by the current scenario, what I personally feel for India, that we should designate one hospital only in one place. If every hospital start taking patients, then it will be difficult for everyone to manage the thing. Say for a condition arise where one hospital cannot and it is spill over, then it's a different situation. So first we should focus that at one place a designated hospital for COVID patients should be created, where we expect that 15 or 20, 15-20% patients of our population who will probably get sick, and 5% will need ICU bed. Means whatever bed we are creating, at least 50 or 40% be ICU bed, and next 60% should be non-ICU bed. But what especially you are asking about the medium segment hospital and large segment hospital, it will not work if you do not have a two separate area where your COVID patient can be segregated from routine patient. So even you have medium segment, even if you are large segment, you have to be very, very clear that the area where COVID patient will be treated, the staff who will handle the COVID patient, the doctor who will handle the COVID patient, they should not mix with the other patient. Because once you start, there are a lot of incidences where patient came for some other problem and patient died because of the COVID. We have to be very, very clear on this regard. That first thing is that we need a separation of this thing. Now, what preparation? A basic, we can divide hospital in three segments: primary, secondary, and tertiary level hospital. But for sake when that condition arises, when we spill over, in primary level, like more of the quarantine, a patient who needs symptomatic care, more of the general care is fine. But if patient become breathless, if patient need oxygen, he should go a place where at least he could be given oxygen, proper oxygen treatment. He can, if needed, he can be intubated, and if needed, he will be put on ventilator. And now issue is that any hospital who is ready to prepare to intubate this patient or ventilate this patient, they have to be prepared at least for the basic requirement, like for intubation. If you do not have video laryngoscope, which most of the hospitals do not have, then you have to be ready for the, at least to distance from there some alternative way, like distancing or some barriers between that, if patient situation should not come out. Everybody should be trained about that, how to intubate. So if you cannot train your hospital or staff or doctor how to intubate and ventilate, probably you should not be taken. PP requirement, if you have enough, like suppose you cannot have more than 6 hours shift for your staff when they are in PP. So you have to, like, suppose you designate 10 ICU bed for the COVID patient. For this, you are going to compromise the quality, even if 4 staff taking care of those patients. But everybody will need PP, enough PP. In one shift, there will be 4 or 6 staff, 2 attendant, 1 doctor. We have to completely restrict the visitors. They are not allowed. It's like that, whatever you are doing, you're doing. So at least a minimum requirement of oxygen, minimum requirement for intubation set, minimum requirement for ventilator, as many beds you are creating. Maybe I will say that we should not focus too much on an IV. We should just focus on oxygen therapy in form of either non-rebreathing mask, not even HFNC, or directly go to intubate. So at least if we can focus very clearly that we need this many staff according to the bed per shift, they will be overworked. So that backup is very important. They will fall sick. They will not able to go to home. How will we take care of them? So that issue will also come. Then after the staff, minimum requirement for intubation kit. How will you clean that kit? How many set of intubation kit you need to have? At least 2 minimum, and you need to properly clean that. Followed by ventilator requirement. If you are having 10 bed and 10 ventilator bed, then what you are going to do with the routine patient? So this will be the logistic issue. Coming to the larger hospital, it will all depend upon how many bed you want to handle. Suppose you have a 200, 300 or 400 bed hospital, you are going to dedicate that. At least you will have to dedicate 40% of your bed for the COVID patient in ICU. 60% patient you can keep under observation, because it is very well known that if 15% those patients who are going to sick, most 40 or 50% may need ventilator. So we may divide our resources like that. So if you have to summarize, very basic minimum requirement for resources, then we have to focus for PP, train our people, need enough intubation set, intubating kit, and ventilator. They're the basic requirement. I hope I'm clear.
Thanks, Rajesh. I think in summary, what you say is that for the current scenario, you probably have to have a nodal center in each city.
That is the first thing. That will be the first priority. And if it's still over, then we go ahead bigger things.
Yeah. Sure. So anyway, the next question will be to Dr. Yash Zaveri. I think a part of it has already been covered. Yash, are you around? He's muted, is it? Raja, I can't hear you. You're muted yourself.
Hey, can you just
Sir, I'm not able to see his audio connection, sir. I think Dr. Yash could connect audio.
I can see Dr. Yash.
Back to him later, perhaps. Dr. Justin, are you around? Can you hear me?
Yes, yes. Yeah.
I think Rajesh has elaborated a bit on staffing. What are your thoughts about a little more in detail about the medical nursing, allied healthcare professional regarding preparation for a large-scale epidemic? I'm not talking about the current scenario, but say if there should be more than a hospital that needs to be involved, or if you're talking about the proportion of patients that we see today in Europe or in US. So just wanted to know regarding the staffing, what are your suggestions in terms of numbers, taking care of them, rotation, and such other things. And after that, if Rajesh has anything to add, he could add on as well. Justin, start with him.
So we will start with the way how the epidemic evolves, or pandemic evolves. So it has got stages, and based on the stages how we progress, and by the time stage 3 happens, it escalates differently in different countries based on whatever the other measures that we have taken. We have seen US and UK have Italy taken off quite steeply, whereas we have not. Even though we did not think we were in stage 3, we have sort of getting there now. So based on these, we have prepared for how Italy would do, or at least we're preparing at this point how Italy would do. Let's say that's the higher end, as you suggested. So there are 3 models. We had some ongoing survey that is happening with 6 different countries. We are asking. Already we had about 28 big ICUs that are part of this. They've responded, and the opinion is very varied, and it all based on the way how it exploded in each country. So the countries like UK and Italy, where the answers that came from is like the minute they had an escalation all out, as in everybody had their leaves cut, everybody had to be at work, and so on and so forth, which is called full escalation. And there are some other countries which had extremely low escalation, like in Japan. A couple of my friends are there. So Japan had no escalation at all. There are half the staff were left out because the hospitals were emptied, expecting a big surge, and there were quite a few people who were kept as reserve just in case if somebody falls sick, and they could join in sort of very low escalation. The middle one, which is what we call as the graded escalation, which is what we are following in our own hospital, is to set aside both staff, place, staff of various grades, both consultants or the trainee or middle grade people, and the nurses and the support staff, is separate with the escalating dose with each phase. So most of them started responding the minute there is a case in the country. They have made some plans. The minute there are cases admitted to the ICU, they've gone on to either full escalation, graded escalation, or no escalation, or low escalation. So we are in our own hospital where I come from, Manipal Hospital. We have done the graded escalation where we had an isolation bay, isolation doctors specifically rostered for that area, both the consultants, middle grade, and the nurses. So which number continues to increase, which gives us, at least in an Indian setting where we are, where the curve has not been so steep, it allowed us to train our rest of the team, both the doctors as well as the nurses, in terms of use of PPEs or getting the system, or what we call the process of how the patient is triaged, comes to ICU, goes out of the ICU, and all the process in between. So we were lucky in a way to say that it has not been steep and it gave us a bit more time, but in countries where it did not, we could see that in China particularly, and in Italy, where they did not have time to prepare, the initial phase, the number of healthcare workers getting infected was very high. But once they got time, the numbers have come down. So in a sense, each country has its own way, but for us in India, particularly given the slow steep, we are getting away with what we call as a graded escalation, both in terms of space and personnel.
Sure. Rajesh, anything to add?
Rajesh could.
Okay, we'll move on to the next one. Dr. Farooq, I know a lot of, and Pradeep, both of you, if you could just sort of summarize, I know there's been a...
Sunil, is Dilip not there? Dilip Raman?
Yeah, I'm here.
Oh, okay.
Yeah, I think he's down the line. I'll after this, the next question will be to Dilip, the next few rather.
Sure.
So Dilip himself has also given me a to go ahead with this. Just quickly, Pradeep and Farooq, if you could, as Pradeep rightly mentioned, there's a lot of noise regarding the treatment aspect with sort of, I would say, not well-tested studies or not well-done studies from what we have today. So can you give one sentence or a two-sentence guideline for the benefit of the viewers regarding what you would consider as the most appropriate combination of drugs for treatment as of today, which probably is dynamic, but as of today, which you think would be the most appropriate, and what category of patients you would think would be the best to be chosen to be treated? Pradeep and Farooq, please. Farooq, are you there? Farooq? Pradeep, can you take it up? He's not to be heard.
Yeah, Sunil, can you just very briefly tell me again, because I was getting another call from SJVery. Can you just very briefly repeat the question?
No, I was just saying, can you, in a sentence or two, summarize what you would recommend for the benefit of the viewers as the most appropriate line of therapy in terms of therapeutics for antivirals for somebody who presents with COVID, positive COVID? I mean, let alone the noise that we have with all the various types of treatment today, as of today. I know things may change tomorrow, but what you would recommend as the treatment of choice for a patient with COVID?
Yeah, I think Anup's talk was pretty comprehensive, Sunil.
Yes.
So if it is a very mild case,
just one-liner, yeah.
Yeah, if it's a mild case, I wouldn't treat with anything. But if it is a symptomatic case needing hospital admission, then obviously I would use hydroxychloroquine with whatever evidence. And because there is a recent, just one day back, there is a article came which showed some benefit. So I would use hydroxychloroquine with azithromycin,
Sure.
but clearly monitoring the QT interval. I wouldn't jump my guns into lopinavir, ritonavir, or IL-6 antibodies and all that. And it's not available as well.
Yeah.
So at this point of time, I would confine with that with symptomatic treatment.
And your thoughts on prophylaxis?
Yeah, prophylaxis is hugely debatable. I would reserve it at this point of time for only the frontline people who are caring for COVID and who are very apprehensive and they want some protection. I would just follow that ICMR recommendation, Sunil, just to alleviate their apprehensions and anxiety and feel little protected.
True.
Yeah, I'm okay, ready.
Yeah, sorry, you're there, Farooq?
Yeah, I'm ready now. My mic is on now.
Yes, you're in. Great. Yeah. So yes, I just had, I think some of it has already been touched. In a couple of lines, if you could just say what are the contingency plans that you would want a large hospital to be ready with if you're talking about a large epidemic likely to hit us. I think it's already been sort of discussed. If you could just summarize it as 1, 2, 3, 4 points.
The ICU preparedness has to be there. Contingency plan for a epidemic of the size as in of counts and oxymoron. But whatever we have to plan. We have to plan with small areas, that if we have small numbers, we start with small dirty areas, will be COVID areas. Then as we grow in number, we completely take over the hospital in phases. At the same time, we need to have neat and clean areas for non-COVID suspects or non-confirmed cases. The resources which we have to prepare, we have to have our formulary ready, which includes the equipment as well as the drugs. We need to have our manpower, which has been discussed earlier also. The main issue in manpower is risk mitigation. We have to keep our troops hale and hearty. We have to avoid infections in our healthcare provider. So we have to be very, very careful with PPE again. We have to have a network of resource sharing with our hospitals and our authorities in our areas. We have to vacate our hospitals. All electives should be cancelled. We should not become hotspots or clusters of infection in universities. Thank you.
Sure. Thank you, Yash. Dilip, you have been in the tele-ICU field for a while now and have been supporting various ICUs overseas as well. Can you just share your experience about remote monitoring and management of patients with COVID positive or COVID infection in the ICU?
Yeah, thanks for the question. Yes, we do have some early expertise coming out of the US where we've seen, about 20 odd sick patients now over the last week or so, just, doing sporadic night work. And it's quite incredible, the level of illness, severity that they're experiencing. And they've tried all kinds of treatments. And as we've seen from Gattinoni's paper and other observers, there is a significant dichotomy in terms of two different phenotypic relationships. So we're dealing with that on a real-time basis. But what is coming out really strongly is that they are swamped with patients. Their resources are not able to scale up. They are having 22 beds that are overflowing and become 45-bed ICUs within a span of 3 days. So while I'm listening to this interesting conversation, something that is coming to me is we're all talking about starting a nodal center and scaling it. How quickly can we do the scaling? Because this population can hit you over a period of 7 days, 3 days, 2 days. It can be pretty quick. Just to put that in perspective, Bangalore has a population of about 10 million people, 8 million if you go by the metro census. If you do the numbers and if you say that 30% of them are going to get infected, and out of that number, 15% are going to come to the ICU, you might be looking at daily admissions of 1,500 ICU cases per day on the average end of the projected spectrum. That is a sobering number. We are not going to be able to get away with a 20-bed ICU for the city. So we may have to scale on a range that we haven't seen before. These are events that are known as black swan events. And if the West is any warning, we probably need to look at innovative solutions to figure out how we can handle this deluge that may come. Now, the hope is that, fresh air, temperate climate, BCG can all make an impact. But I doubt that the impact is going to be a 75% reduction or an 80% reduction, because the reduction will have to be at that scale for us to not get the impact in the ICU. So just to put that in perspective, I think the overseas experience is very sobering, and we just need to be open and prepared for what may come and have innovative Indian-centric solutions to try and solve this, to conserve PPE, to conserve our manpower, as Dr. Yash and Dr. Mishra has pointed out. We need to protect our resources and rationally use them according to that NEJM paper that Pradeep was talking about. Thank you.
So, Dilip, how do you think we could extrapolate your experience and whatever you have suggested with the enormity of the problem to the Indian context, and where do you think tele-ICU or e-ICU has a role, or let me put it more broadly, technology?
Yeah. I think technology is going to be central because that is the one thing that can be scaled up faster than any human resource right now. So one of the things, for example, that we put forth in a position paper is to really loosen the guidelines to the Indian setting. So for example, there is immense focus on negative pressure rooms. We've spoken to multiple hospital establishments. Let's face it, there are 4,632 intensivists in India, qualified people, many of them in this call. And we definitely realize that it's impossible to set up a 50-bed negative pressure room in every hospital. It's not going to happen. Let us use our temperate climate, our natural ventilation to our advantage. WHO already mandates for natural ventilation. Natural ventilation flow rates can be in excess of 20 changes per room, which is much faster than the 12 that they're recommending. We just need to augment that with exhaust fans, and these units, the open air ICU concept that I strongly push for, can be easily set up quickly at scale in medical colleges, district hospitals, and even private setups. That's one. Number two, after we do this open air concept, we could look at oxygen at scale. Obviously, if government can provide oxygen, that is something that they need to put on, priority number one after PPE. They will need to allow us to use high flow and nasal cannula and non-rebreathers as the go-to first option, because even Western experience suggests that NIV is not particularly useful. There is this concern about aerosols and high flow. I mean, looking at the research on it, it's really not that good. Most of it is speculative, saying that high flow may cause aerosols to arise. But if you look at it, the peak cough flow is around 400 liters per minute. The average respiratory minute ventilation of a patient with ARDS is about 20 to 25 liters per minute when they're with increased work of breathing. And a high flow is about 30 to 40 in the same range. So you're not going to be getting that much aerosols if your nasal seal is not that bad. Now, there's a question that open air ICUs may be a risk for surrounding areas. You know, if you have appropriate natural ventilation, that is a risk benefit strategy we may well be forced to take. We may not have the option to decide on HEPA filters all over. So this is something that we really need to keep in mind, is let's not let perfection be the enemy of good. Let us do what is good and not aim for perfect, because we will not be getting perfection at scale. So the other question that comes up is, you know, splitters and all these other low-cost technology-based ventilators that are coming through. Almost everyone on this panel probably knows that it's very hard to take care of a ventilated patient. You're better off taking perfect care of an intubated patient, preventing VILI and VAP, rather than giving substandard care to a multiple group of patients. You're not even going to be able to stack these multiple patients who are on a splitter one over the other and prevent infection. Tidal volume challenges are going to be there. You're going to have a lot of ventilator-induced lung injury. So let's be a little practical about that. And what we are encouraging is a really close dynamic with engineers and technologists around us, so that we can devise quick solutions like cheaper, faster manufacturing of high-flow nasal cannula that are more likely to give you the quantum of benefit that NEJM paper was talking about. Try to treat 80% of the population, then to focus on the 2 or 5% of the population, because we have to do this for the greater good. The ethical principle of distributive justice has never been more important than in a pandemic setting.
Thank you, Dilip. Justin, you have been involved. I think Dilip has covered a lot of ground. But you have yourself has had some personal experience tying up with a few people and a few like-minded scientists around from the non-medical background as well. So what can you share some of your experience about what are the newer innovations that are being tried out at this point of time to try to bridge the gap of this demand supply mismatch, which is likely to come?
So in reality, the answers will be what we call hacks of what could be sort of increased in number at a shorter period of time. And for this, Indian Institute of Science has come up, and I've been working with them on about 5 projects. First one was splitters. Obviously, Americans have come up saying that it probably is not safe, but at the end of the day, we wanted to keep those things, and we've tested, and the Indian Institute of Sciences have printed, and we've put out open source for the design. That's thanks to them. In our ICU, we've been able to put both controls through it, and it seems to work well, at least functionally. Number 2 project was that we've been doing indigenous ventilators, sub 50,000 rupees ventilators. So it took, I think, 42,000 for them to source parts for ventilators. So it is not like what we have seen on WhatsApps. This is actually a mix of bird and a boils together, and with a PEEP valve. So the traditional PEEP valve that we have on ambu bag, it's fitted into the circuit, and it can just dial up to 20 centimeters. So essentially, in the acute phase, you could use it like any other ventilator until you need a pressure supported ventilation. They are planning to get a device onto it in the version 2, so that would allow even pressure support also. All these things, if they are mass produced, will come down probably to well under 30,000 or 25,000 itself. So that is again open source. It's on the web in the Indian Institute of Science. The third project was about reusing N95 masks, which I think whole world is trying to. So the commonest mask that we tend to use is the 3M mask, and they have categorically said not to reuse in their sort of leaflet on a website. But the reasons they gave was because they could not confirm the fit test after you sterilize with whatever. Sterilization itself is not a problem. N95's mask is withstanding either ETO, wet sterilization, UV, or H2O2, whichever we've seen, seem to kill the viruses adequately and not damage the mask itself. But the fit is not confirmed. So as long as fit test is good, I think we can still use it. So we have used some of the masks and sent to IIS. They are trying to create aerosols, so that's a work in progress. The other one is that they have created a UV box. Indian Institute of Sciences, along with a third party, has created a UV box. It's a small box to have about 10 to 15 masks at a single set to go. So that's probably in a couple of days will be trialed at our place. So we are hoping to receive the box. So that's also done. So there are lots of these projects. So number fourth is that the project another 2 days is the hack of high flow machine. So I think IIS students had some humidification as a project 2 or 3 years ago. Along with it, we are trying to get a blender for the wall socket. So we're trying to hack the nasal high flow on a large scale. After hearing Dilip, we went back to the drawing board, and they are trying hard to see if that can be facilitated. So there are a lot of these projects that are going on. With not just, I mean, I obviously knew Indian Institute of Sciences through context, but there are many people who are doing this thing. I think what they do is that they bring a lot of energy to the situation by interacting with them. We tend to see a lot of worry, anxiety, cynicism at workplace, awaiting the so-called surge of the COVID. So, in general, I think, irrespective of some of these, don't necessarily see the day of light in the real practice. But the energy that I come back with seem to put a lot more positive thought into how I approach this impending pandemic.
Sunil, I've seen a couple of questions pop up, and I can probably wrap that up quickly.
Sure.
I just saw a question about AI and telemedicine, so I can just take care of that.
Yeah.
See, one of the things that I would immediately suggest is to install teletriage in every hospital possible. It's extremely easy to do. We've already sort of given a idea on how to do it. We can share it with whoever needs to. It can be done overnight, and you can reduce your inflow and infectivity into the hospital and keep your staff safe, as we all need to. The second thing to figure out is that tele-ICU models in the US and also the world over can be extremely efficient at safeguarding the intensivist resource. So you can, on a traditional day, if one intensivist is covering 15 beds, your expertise through the screen, through looking at these ventilator graphics, figuring out who needs to transition from high flow to the ventilator, who can stay on high flow, can be done at a scale of around 1:60 or 1:80. So that is a tremendous offset that you can provide to the critically ill population that may swell up by using a tele-ICU network. And you're going to save a lot on PPE as well, because some of the monitoring of the nurses themselves can be done from outside the ICU. So they don't need to gown, change, go back in multiple times, because as the doctors have already pointed out earlier, 80% of these patients are not going to be very sick. So don't use PPEs on these patients. If you need to constantly monitor them, you can remotely do that. There are a lot of technological solutions that you can use right away without any learning time or resources to put this in place. So you save your personnel, you ration them well, and you save on PPE. So be open to that concept of tele-ICUs and telemedicine, because it's going to help you.
Yeah, one line, can I?
Yes.
Yeah. As Dilip already pointed out, we have to save our resources also. So in the screening areas also, one person should be there. It could be a doctor or it could be a senior nurse. We have to save them. We have to save our PPEs. All the screening areas, all the OPDs, if they can have an electronic interface rather than a personal interface, it could be WhatsApp, it could be Skype, it could be your routine audio, visual, or CCTV cameras of the hospital. So we have to use an electronic interface for screening as well.
Sure. One question is there on the chat, which says...
sorry to interrupt. Vinay here. Dr. Riaz from UK wanted to add some 2 points.
Sure, please. Yeah.
I'll unmute him, sir. Dr. Riaz, you can talk.
Yeah, hi there. Hi. It's quite interesting, and at the Kingdom. It's very useful talk, and it's just so reassuring to know the amount of work that's actually going on in India as a preparatory work. Now, as you know, we are already in the mid things. We're already in the thick of things. And it was quite interesting discussions. I think some of the few things I just like to add quickly because I don't want to eat up your time. It's about cohorting of patients. Now, about the, when I heard people talking about nodal hospitals and surrounding, you go on as you develop as you go. But one of the things that people have to understand from this experience so far is the rapid surge that happens. And when the rapid surge happens, sometimes no level of planning can help, and then it's a war-like situation. And I think that's where we've got to think smart, think quickly in a short period of time. Now, in London, we have built that 4,000-bedded hospital, which is actually going on. One of the worries I have in India is the preparatory work is superb and massive, but when this hits a surge, the amount of resources you can have in terms of ventilators, within that short period of time, that's the most important bit, and that's where you tend to think about the ethical issues around which patients you tend to give the ventilators or not. In the good old days when I was in India, we had to shift oxygen from one patient to the other. So I think in terms of planning, what you have to do, I think it's about, one is the time limited constraints that you have. Hopefully the surge won't come. It's, India is doing a fantastic job. I'm from Kerala; they're doing even better, and I think it's a great thing that you're doing, which Britain didn't do. The Britain did not prepare well, and they didn't do it. So one of the most important things about triaging, and the other thing is about the mental support you got to give to your colleagues and the people around you, and that's very important. The nurses. Now, sadly, I just heard today a 35-year-old nurse who was working in a joint hospital died, sadly. So young people are dying, and we increasingly are seeing a lot of young people in our intensive care in America and also in the United Kingdom. This is something you also have to be prepared for, mainly ethical sense. What you got to do? How do you make those difficult decisions? How do you make those ethical decisions? So, and this is actually coming from experience. I think a colleague of mine works in St. Thomas's in London. They already have about 250 patients in intensive care, and QE Hospital in Birmingham has got about 500 ITU beds, which is being prepared. So the point I'm trying to really say is the scale we're talking about is massive when you hit the surge, and that's real practical stuff. And I think excellent talk is going on, and excellent innovations are going on. It's very heartful to know that that's happening, but I think it's worth trying to step and think of those sort of the surge that happens, because then I think a lot of the planning goes out the window. And I think somebody did comment on it, but I got to say that the level of talk is absolutely excellent and brilliant, and keep going, guys, and you've done a great job.
Thanks, Riaz. Thank you so much for your kind words, Riaz.
Thank you. There's one question on should we consider hello?
Yeah, we can hear you.
Yeah, there's one question on whether we should consider jet ventilation as a modality for sparing ventilators in patients with ARDS.
No, jet ventilation is a big no. Jet ventilation is a big no because it generates a lot of error. So it's a big no.
Yeah. And also, I think the high frequency ventilation, that's the question. And not only the aerosol, we are also talking about lack of benefit, which has been shown from the previous ARDS studies as well, isn't it?
That's right.
Yeah. Okay, there's one question. It said, why do we need to maintain, I think Dr. Lotte has asked, why do we need to maintain 2 meters as the dead code? Yeah, somebody had asked, it's already been answered. Okay, fine. How do we protect the X-ray cassette? Yeah. How do we protect the X-ray cassette during and the decontamination procedure? Do you want to take that, Ajit?
I'm not very sure.
How do you decontaminate the X-ray cassette when you have used it on a COVID positive patient?
No, I have not read anything. I have not read anything very specific about that. Somebody can answer, that'll be fine.
Yeah. I'll do that. Sunil?
Yeah. Yes. Go ahead, yeah.
You have to cover the cassette with a transparent cover. The machine also has to be covered with a transparent cover. It is better to have a dedicated machine for COVID patients and COVID areas if it is a big hospital, you can divide your machines into two. If it is a small hospital, then only do it for COVID and leave others apart. Cover with a transparent disposable covering.
That's a great idea.
Yes. Sunil.
Yes, go on. Tell me.
Sunil, the problem with this virus, you cannot take out any of these machines and whatever you are doing out of the COVID area. So when you have used that machine, then you have to either very deep clean it properly, everything, because this virus can survive on metal for 8 to 10 hours. So either you keep a dedicated machine for X-ray. That's why I said you need a nodal center.
Yeah.
To wait. You cannot have the same machine.
Yeah, it may be
same machine moving to everywhere. You have to dedicate in the same area. You cannot move it out.
Yeah, so it may be a good idea to zone these patients, as you said, and keep a dedicated machine for this.
Any of these thing of this patient, because X-ray plate has to go to the main room for development. That's why it needs to be completely sealed, like the way you are doing for PP. Once you take X-ray, very cleanly take out the covering, and when it is off, it should be off of the, and then dispose that thing, and then make sure that you do not mix that removing. Like you remove PP, same way you have to remove the covering of the X-ray plate. Otherwise, you are again going to take that infection from the COVID patient to the X-ray room.
True. Okay, there are a few questions which have probably partially been addressed as well. So I think we will call off the session now. It's been a long time. All of you are with panelists.